Okay, let's get started again. This is our research talk session 1. I'd like to introduce the session chair, Chris Miller, who is associate professor in astronomy and also a member of the Symposium program committee. You can take it from here, Chris.
Good morning, everyone. This is the first of our 2 research sessions. There'll be another one tomorrow at 9 a.m. We'll have about 15 to 20 minutes per research talk. These talks are from researchers here at the University of Michigan. And the idea behind these talks is that the audience gets to see a fairly broad range of research that's happening here at the University of Michigan. And so I do hope you can pick that out in these talks. We'll get started right away here. If we run out of time for questions, we'll push them into the networking session and we'll have time there. But our first talk is from Bhramar Mukherjee and Lauren Beesley, and they are from the School of Public Health. Bhramar is the chair over there in Biostatistics, and Lauren is a postdoctoral researcher. And they're going to talk about the testing paradox in this COVID-19 era. And I will hand it off to Bhramar and Lauren.
Thank you so much, Chris, and greetings from New Delhi. I am doing international telecommuting for 1 month, for the next 1 month. And so please let me know if you can hear me okay and the sound is all right.
Perfect.
All right. So the testing paradox. So we have heard a lot about testing in the media from statisticians. So the testing for COVID-19, if you test more, you'll find more. So how to render a mathematical framework to this problem, that's going to be the story of the day today. And I'm going to be presenting with Lauren Beesley, who is a postdoctoral fellow at the Department of Biostatistics as well. And I particularly want to acknowledge, this is the first time we are giving this talk. I chose this topic because this work was actually funded by one of the MIDAS pods grants. So very thankful to MIDAS for providing the funding over the summer, which led to this work. So it takes a village to do any work. So we have an army of data warriors at the Department of Biostatistics at the University of Michigan. So this is our study team, but Jiasung Du, my PhD student, and Lauren did the heavy lifting here. So I want to mention that this debate about case counts, that the case counts that are being reported for coronavirus cases all across the world are meaningless. This debate has been going on. You can see from April, Nate Silver said that these case counts are completely meaningless unless you know something about the testing strategy. And even then it gets complicated. So we are going to share some snapshots of that complication in terms of a statistical model today. And so if you look at the different testing strategies all across the world, here is a summary snapshot. United States, you can see that initially we had limited number of tests, but the tests have grown. In India, again, the same story. You can see that in South Korea, they have done a lot of testing, and these yellow grade areas are the test positives. And so you can see that there is a lot of patterns going on here. And if I put in the case counts of all of these countries on the same platform, without thinking about the confirmed cases per million, the number of tests that they are doing, and the testing strategy, who are you testing, then you are almost committing a statistical sin. And you are analyzing the data in a same platform. So how do you think about these? So the challenges. So let us think about the statistical problem, and I'm going to put forward a framework, and Lauren is going to show you the most important contribution of this work, a Shiny app that administrators and public health officials can play around with. So the constraint is that we only have a limited fixed number of tests or budget. So if you could test everyone every day, we'll do it. There are ethical concerns and other social concerns, but we'll do it. But the tests are also imperfect. So the coronavirus test, there are different kinds of tests. And here I'm mainly talking about diagnostic tests. So I'm not talking about serology tests, which is for past infections. I'm just talking about active infection tests. And these tests are imperfect, particularly in terms of their high rates of false negative. somewhere ranging between 20 to 30% for the RT-PCR test, but also the cheaper saliva tests that are being used, somewhere around 40 to 50%. So how do we take those into account as we think about testing? So there have been a few papers, and mostly actually by economists, about how to do testing. So some of this literature focuses on how many tests should you do per day. And then if you have two different kinds of tests, how are you going to allocate a cheap test, which is less accurate, with an expensive test, which is more accurate? Many people have suggested this pooled testing strategy, where you actually take the specimen from several people, and if at least one turns out to be positive, then you go on do individual testing to save costs. And then stratified periodic testing, this is again a paper by an economist, where they say that you need to really target risk stratified population and then test them repeatedly at a regular interval. So our aim is to come up with a mathematical framework about how to allocate tests optimally across population strata, defined by symptom severity, and also other risk factors. So this cartoon sort of tells you that who is going to get the swab. Is it going to be the sick people who are showing the symptoms? Is it going to be the young? Is it going to be the old? Are we going to test children? What is optimal? So when you talk about optimality, of course, you have to establish a criteria. You cannot be vague. It cannot be ad hoc. So the context to keep in mind is that the goal of your testing strategy may be changing. So when you are in the growing phase of the pandemic, you may want to detect as many cases as possible. And when you are in the containment period, then maybe you are just doing surveillance and trying to see whether the number of cases or the test positive rate exceeds a certain threshold. So it's not going to be a blanket optimal strategy which matches with the goal of where you are at. So by that, I mean that this is the case count, this is the case trajectory from New York City. And you can see in the beginning period, when you don't have as many tests and you are in the growing period of the pandemic, you are trying to catch as many cases as possible. And then in the containment period, you may want to just say, I am waiting to see when the test positive rate exceeds a certain threshold. That's my outbreak alert threshold. So in all of this talk, we're going to use this notation G. Generation G will denote that the average time it takes for an infected person to transmit the virus to another person. And in the literature from Wuhan and all over the world, it is estimated as with a mean of 5.2 days, and there is a distribution around it. So this is the slide. If you're playing with your phone or another screen, if you pay attention, this is the only slide that you should pay attention to. This is the mathematical framework that outlines what is going to go on in the rest of the talk. So as statisticians, when we look at this problem, we think about models and we think about a mathematical framework because we can just start with a random test strategy and see what it gives us. But let us just really formulate it. So in a generation G, we have the number of tests T sub G. That's going to be our assumption, starting parameter. And if you have certain tests that you must give, for example, essential workers, health workers, TG may be just the number of available tests to you that you are at your disposition to give people. And then this is the true state of nature, whether you have the infection or do not have the infection. Z are some covariates which are predictive of your risk. And then there is because most of the states and the counties are doing symptomatic testing. So you can see it in a prioritized basis. So you see severe, mild, and asymptomatics in both the groups, whether you have the active infection, the virus, or you have a similar flu-like illnesses, we cannot discern until we do the test. So we can see the symptoms and then the selection probability of who gets tested. And as I said, the tests are not perfect. So you are going to have some true positives, some true negatives, and then some false positives and some false negatives as well. So this is the structure through which the data is being formatted. And as statisticians, we are going to assume that what is your symptom probability if you truly have the disease and if you do not have the disease. And you can get this data from CDC and other health department websites that what is the probability of showing different symptoms. And for simplicity, we are going to just simplify this into 3 symptoms category: severe, mild, and asymptomatic. And Z is a covariate. And let us think just as categorical, because the continuous case is much more difficult. And then you have a model for the imperfection of the test, because this is something really you need to take into account, the sensitivity and the specificity. So then your testing strategy is nothing but who are you choosing for getting tested, conditional on your symptoms, conditional your true disease status, and the condition, and then you have the ZI, the risk covariates. So given these formulation, you can actually write down what should be the number of positive tests that you detect if you have capital N as the population size and D sub G is the true number of cases that you have in the population at generation G. Now what happens is that with this, you see that you have this testing strategy is something that you're trying to optimize on. So suppose Z has 4 categories, 4 age strata, symptom has 3 categories, then there are 12 probabilities that you're trying to optimize. Who are you going to test? So in terms of optimization, you can think about, this is also a key slide where you have to specify, we are specifying a loss function depending on our goals. And the goal is that in the growing phase of the pandemic, so it's a weighted loss function. And the first part talks about you're trying to get as many cases as possible. And so this is the detection mode. And the second part is that when does it exceed that threshold? So you're in a surveillance mode. And there are 2 constraints that I always want to test the severe symptoms. I cannot ignore them regardless of their disease status. I have to select them for testing. And then I also want to make sure that the number of tests is less than equal to what I have available. So these 2, and then you can optimize this in terms of a discrete optimization problem. And as I said, in the first part, so let us just say if W was 1, then you only have this loss function. And we're thinking about where we are in the growing phase of the pandemic, and you are trying to detect as many cases as possible. So this is we are going to call a detection mode. And then the outbreak watch mode, that when you are in the control mode of the pandemic, you're here and you're trying to say that I'm watching it when the test positive rate or the community prevalence is going to exceed a certain threshold. So this is, given that, I'm just going to show you some snapshots, and Lauren is going to actually show you how to some slides on how to play with the app. We basically did mimic the distribution. So I'm going to take Z as just a toy example as 4 age groups, and the probability of being asymptomatic for us infected individual is going to be the parameter that we vary, as well as the number of available tests. And then we can get some of these parameters, historic data from the literature. And I'm going to, when I show the surveillance mode, I'm going to just fix the outbreak threshold at 3%. Who has suggested like 5%? Some people have suggested 1% at as that threshold. So you can play around with it. So when you have this, so what is this optimization is giving you is that as a function of your parameters, what is the optimal distribution for the symptomatic people, for the asymptomatic people? And there are many scenarios that you can consider. For example, in the beginning part of the pandemic, you have limited number of tests. And so you see that if you are giving it to, and the probability of being asymptomatic with the infection is around 0.55, 0.6 for coronavirus. And so you see that you get most of your tests to symptomatic people, mildly symptomatic and severe symptomatic people, and it does not go to the asymptomatic people. So the test strategies that were followed for limited tests, they have some justification. And the same thing for young versus old. The older people have more chances of showing symptoms and fatality, so you give more tests. So that's very obvious. But when it comes to the stratified distribution, when are you going to test someone who has mild symptoms but old, and then the trade-off between asymptomatic and old and severely ill and young, that's when this optimization comes into play. And you can see that if you have, you will test fewer young asymptomatic people when you have limited number of tests. But when the situation, you have abundant number of tests, the situation really changes, and you end up in testing a lot of asymptomatic people as your optimal strategy. So this is in the detection mode. And then when you're in the surveillance mode, something opposite happens, that we see that we typically need fewer tests theoretically. Ideologically and in terms of principle, what you're going to do is very different. But you can see that in this case, you end up in intensified screening of elderly asymptomatics, because there is not just that much prevalence and you have a lot of tests left. Who are you going to watch for? So this is something that you have a mathematical framework for doing this, and we tried to mimic New York City data, and where the true number of cases, undetected cases, we assume that it's 4 times the number of reported cases. That's sort of the underreporting factor all over the world. And what we see is that in the beginning part, we are in the limited number of test situation. And in the growing phase, then we come to abandoned tests. There are more tests available. But then once you cross that 3% threshold, what we propose as the strategy, and we see a lot more tests are being done here, and our optimization algorithm says that in the control phase, about 55% of the total tests could have been done. So, and with our strategy, we see that we can actually replicate this virus curve quite well. So it seems like it's a sensible strategy. And the second part of our work, and I don't have time to go through this in detail, but what I talked about is campus testing, right? So we have had a lot of debate about 2 tests that we have: an RT-PCR test, which is very expensive, takes time, but is more accurate; a saliva test, which is inexpensive, and we have raging debates across the campus. Should we test asymptomatics? And several statements have been made. And you can see that this is Harvard, UIUC, Cornell, and Michigan in the last 1 week, around November 2nd, and how many tests they're doing, and what are the number of cases from their publicly available dashboards. And so the question is that if you have 2 different tests, then and a given budget, how are you going to do the optimization? And so again, we are considering 2 tests here. One is the RT-PCR test, and one is the cheap saliva test. Then what we see is that, and we have costs. One is a cheap test, the RT-PCR, say $150, and the antigen test, the saliva test, $5, but with a lower sensitivity. How do you optimize, and how do you spend your budget? And we can find out the optimal strategy. What we see is very obvious, and what is being done, that the antigen test, the cheaper test, should be used for the asymptomatics, and the RT-PCR test should be saved for the symptomatics. So, but for different configurations, these types of mathematical formulation can render some rigor to how testing strategies are being thought about, and when statements are being made that who we need to test. So with that, I think that I'll just hand it over to Lauren to just show the Shiny app. And there are some limitations of this work, as in all, but this is, you have to attempt to formulate this, and that I think is the only contribution of this work. So Lauren?
All right, let me share my screen. So in the chat, I have, can you hear me?
Yes.
Yeah.
Yes,
Okay. So in the chat, I pasted some information. So right now, we actually don't have a website. In the future, we'll have a website, so you can just go to a URL. But right now, we have a little snippet of our code that you can run to pull up the app. There are some packages that are required, and it looks like I maybe missed some. Shiny Matrix also needs to be installed. And there's some tweaks that you need to do for Windows users right now. And this is going to get ironed out pretty soon. But right now, I'm just going to give a highlight of what you'll see, you know, if the app is all up and running. So we have some different sort of panels in this app. We start out looking at New York City data. We look at historical case counts data. compare to what if you apply our sort of optimal test strategy, what we might have observed in New York City had we, followed our optimal allocation strategy. And here we're just focusing on that Z that Bhramar mentioned, these risk factor baseline covariates. We're just looking at age stratification. So in the future, users might want to incorporate patient occupation and some other factors in trying to determine test allocation. So in our app, we have sort of different input factors that you can put in to see what would happen in terms of the optimal test strategy. So Bhramar mentioned there's sort of some assumptions as to what the true distribution of cases is in the population. Right now, we're assuming that it's 5 times the number of cases that were actually reported, but you can play around with that and some other properties of the test. So we have sort of different panels. This first one is looking at observed cases in New York, but if you go to the second panel, we can look at some sort of hypothetical population whose age distribution matches New York, size matches New York, but now we can play around with, different number of cases that you might have in the population or the number of available tests. And a key input factor here is what our goal is of testing. So if we're in the case where we have sort of higher prevalence of the disease, where, in a disease outbreak ongoing, our goal is to detect as many cases as possible in our modeling framework. And so we have a certain test allocation. And so these figures show sort of different allocations based on symptoms and age, test positive rates under sort of different assumptions. And then we can compare that with the population distribution to see sort of what degree we're having enriched testing in sort of certain age strata or symptom strata. And we can play around with this. So suppose our goal instead is we have a low population prevalence and we're trying to just sort of surveil for possible outbreaks. And we have some sort of target positivity rate we're trying to hit. And if the population prevalence exceeds that threshold, we're wanting to know. So if this is our goal of testing, the testing strategy that our method would recommend is quite different. And so users can input different quantities, such as the number of available tests, and get what the optimal test strategy would be under our method. And a third approach looks at allocating 2 different tests, as Bhramar said. So we have, for example, a rapid antigen test that is low cost, but sort of less accurate, and then a more expensive but more accurate test like the RT-PCR test. And so how you would allocate that between different symptom strata and also different age categories, although that's not currently being shown. So this particular panel is still somewhat experimental. We're still tweaking some of the constraints for the method, but users can specify the age distribution. So if we're thinking about a university setting, sort of are these younger people, are these older people, and what sort of properties of the test and how many, what our total budget is, and explore how our method would recommend different test allocation in different scenarios. So this is kind of a fun tool that you can use to explore what sort of how we can use limited resources like the total number of tests or limited budget and allocate in order to satisfy different goals. And these goals depend on where we are in the pandemic and what our goals of testing are.
Thank you very much, Lauren. I have to move on to the next talk. So I'm really looking forward to the web app. Actually, this is quite going to be a lot of fun to play with. I can't wait to try it myself. Well done.